Good afternoon, everybody. Please do grab some lunch and take a seat. A very, very warm welcome to today's Think Global, which is called Global Health 2050, the path to halving premature death by mid-century, in which we'll discuss this new report from the Lancet Commission on Investing in Health. And if you're joining us on Zoom, thank you so much for tuning in. My name is Gavin Yamey. I'm the Heimowitz Professor of Global Health here at DGHI and a Professor of Public Policy over in the Sanford School. And I have the very good fortune of leading a merry band of sisters and brothers called the Centre for Policy Impact in Global Health, which serves actually as the secretariat for the Lancet Commission on Investing in Health. I was very privileged to lead the writing of the Global Health 2050 report, and today I'm going to be moderating a panel with 5 of my very brilliant, very dynamic co-authors and co-commissioners, who I'm going to introduce in a minute. But before I do that, allow me to kind of just briefly set the scene for today's discussion. So in 1993, as many of you know, the World Bank published what is probably the most important, most influential, most impactful report in the history of global health, the World Development Report 1993. Those of you who know me know that I am prone to drama and hyperbole. Be that as it may, you'll be going, blimey, the most impactful report ever. That's a very bold claim. I think it's a claim that does stand up to scrutiny. It was unusual. It was an unusual global health report because it was not for a global health audience. It was aimed at the financiers of health, finance ministers and donors. It wasn't preaching to the choir. On the contrary, we're trying to reach an audience who tended to see health as an economic drain. The 1993 World Development Report showed that targeted spending on cost-effective interventions for high-burden, high-priority conditions could rapidly improve health outcomes and boost the economy and promote human welfare. Not a drain, an investment in prosperity. And there's a guy out there by the name of Bill Gates. He read this report on a plane. Apparently he read it twice back to back. I kind of believe it. And he says, every page screamed out that human life was not being valued in the world at large as it should be. My wife Melinda and I were stunned to learn that 11 million children die every year from preventable causes. And that is when we decided to make improving health the focus of our planet. Read the report. Gates Foundation goes on to give $750 million to launch Gavi, the Vaccine Alliance, which has saved an estimated 19 million lives since 2000. So I think that is quite an impact. So that report, WDR 1993, it was commissioned by the former US Treasury Secretary, Larry Summers. He was the chief economist at the bank at the time. And it was led by a health economist called Dean James. Fast forward 20 years to 2013, to mark the 20th anniversary of WDR 1993, the Lancet convenes a new commission, the Commission on Investing in Health, the CPIGH. And our first report in 2013 was called Global Health 2035, a world converging in a generation. By the way, I was at UCSF at the time, but I came to Duke to present this, which led Mike Merson to recruit me, with an assist from Liz Turner, fellow Brit. This report, Global Health 2035, pointed to the promise of a very ambitious but feasible and focused framework for achieving what we called a grand convergence by 2035. And what we meant by that was a universal reduction in deaths from infections and maternal and child health conditions down to the level seen in the best performing middle-income countries. 5 years later, in 2018, on the 40th anniversary of Alma Ata very famous declaration, Health for All, by the year 2000, Alma Ata, 1978, the birthplace of primary healthcare. On the 40-year anniversary, we published our second report, Alma Ata at 40. In that, we assessed progress towards land convergence, a bit mixed, and we reflected on the future of global health through the lens of the push for universal health coverage, our guide star, our lodestar in global health, which we argued was really lacking focus. So here we are today, 6 years on from this second report, and those 6 years really have been defined by a whole host of challenges: geopolitical tensions, conflicts, climate change, growth in nationalistic populism, dwindling concern for global health, slowing progress towards universal health coverage, and of course, the COVID-19 pandemic. Richard Horton, editor of the Lancet, he asked us to get the band back together to re-examine the case for investing in health despite these headwinds. And so we started this CPIGH 3.0 journey just a year ago. We didn't sleep very much. We published the report last week. We launched it at the World Health Summit in Berlin, the Coachella of global health, where I got these mints, no expenses spared. And we made the band bigger, 25 commissioners for the first report. This report has 50 commissioners, with much stronger representation from early career researchers, who we'll hear from today, and from scholars in low and middle income countries. And I'm super thrilled to say that 5 of those authors are with us today, and I'd now like to briefly introduce them in the order in which they will be speaking. Omar Carlson is a visiting research fellow here at DGHI and also over in DUPRI, the Duke Population Research Institute, and is a postdoctoral fellow at the Center for Economic Demography at Lund University in Sweden. Asundu Ogwoji, who I realize is like me wearing a pink shirt and the same colour pants. We didn't coordinate. He's an assistant research professor of global health at DGHI. He's the deputy director and research lead at our Centre for Policy Impact in Global Health, an assistant professor in Duke Population Health Sciences and core faculty at the Duke Margolis Institute of Health Policy. Online, we have Justina Shei Olajide, who is a consultant pediatric surgeon at Lagos University Teaching Hospital in Lagos, Nigeria, and a health systems scholar and researcher who joined us for the launch last week in Berlin. We also have online Simao Chen, an associate professor and head of the research unit for population medicine and public health at the Heidelberg Institute of Global Health. And she's also a visiting professor at the Chinese Academy of Medical Sciences and Peking Union Medical College, China. And we have Damopei Fawole, who trained as a dentist before doing his master's in global health here at DGHI. He is an associate researcher in our Centre for Policy Impact, and he leads projects focused on quantitative health impact assessments and health policy. So, a demographer, a doctor, a surgeon, an economist, and a dentist. We are so well set up. We have all bases covered for our discussion today. So let us return now to this report. It's a hefty one, 54 pages, 310 references, 50 authors, 22 advisors, 10 background research papers. Today, we're going to distill out the 7 key messages, 7. And to get you familiarized with those messages, we are going to kick off, first of all, with a very short video that the Lancet prepared on the 50 by 50.
The value of investing in health has long been recognized. However, rising geopolitical tensions, growing nationalist populism, the impact of climate change and the COVID-19 pandemic have all slowed health progress. So how can we reinvigorate global health? Global Health 2050, a new report by the Lancet Commission on investing in health, shows that focused health investments could drive dramatic improvements in human welfare by the middle of the century. By 2050, countries that choose to do so could reduce by 50% the probability of premature death, i.e. the probability of dying before age 70 years, from pre-pandemic 2019 levels. We call this goal 50 by 50. On average, a person born in 2019 had a 31% chance of dying before age 70 years. If the 50 by 50 goal were achieved globally, a person born in 2050 would have only a 15% chance of dying before age 70 years. Although ambitious, the goal is feasible. 7 of the 30 most populous countries are on track to meet the goal already. The 50 by 50 goal can be achieved through the scale-up of investments and services for just 15 priority health conditions, 8 infectious and maternal health conditions, and 7 non-communicable diseases and injury-related conditions together account for a very large fraction of global disparities in life expectancy. Most of the gains in global life expectancy between 2000 and 2019 were made because of declines in deaths from these 15 conditions. Unfortunately, millions of people still lack access to many basic health services. The vision of universal health coverage has advanced little in recent years, with criticism that the concept is overly broad and uncertainty about how best to implement it. In Global Health 2050, the Commission has proposed a more focused approach to strengthening health systems, providing a suite of core interventions that are likely to be cost-effective and feasible to implement, grouped into 19 modules. These modules address the 15 priority conditions as well as other major demands on health systems, including rehabilitation, child and adolescent development, and palliative care. Together, they set out how countries can best use limited resources to directly improve population health and build resilient health systems. Financing investments in these services must come primarily from domestic health spending. Scaling up these interventions to full coverage by 2050 would require an additional 1% of GDP of health spending in low-income countries and an additional 2% of GDP in lower middle-income countries. There are key economic policies, primarily taxation of tobacco and unhealthy food and drink, and removing fossil fuel subsidies, that would likely benefit health directly and generate revenue that can be used to invest in health services. Development assistance for health should focus on the 15 priority conditions through direct support to countries with the least resources, as well as through financing of global public goods, including tackling antimicrobial resistance, preventing and responding to pandemics, promoting best practices, and developing and deploying new health technologies. The world faces many challenges. It can be easy to feel overwhelmed about the prospects for global health, but the Global Health 2050 report provides a clear, achievable, feasible, and focused plan to improve health and well-being worldwide. It makes the case better than ever for the value of investing in health, for reducing mortality and morbidity, alleviating poverty and growing economies, and improving human welfare.
Omar, kick us off with the first 2 messages on 50 by 50 and the 15 priority conditions.
All right, yeah, thank you, Alan. So the first 2 messages can be summed up in this title here, reaching 50 by 50 through focus on 15 priority conditions. So the headline quote from the report summarizes these messages. That is that dramatic improvements in human welfare are achievable by mid-century with focused health investment. By 2050, countries that choose to do so could reduce by 50% the probability of premature death in their populations, or 50 by 50. This 50 by 50 goal is it's an appropriate goal for this kind of report. First, because it's relevant for all countries, so it's relevant for Norway, for the US, for Nigeria, Indonesia, because all countries have a room for improvement in reducing the probability of premature mortality. It's an ambitious goal, but it's also a feasible goal. So you saw in the video before that 7 countries were on track, given the trend between 2010 and 2019, they were on track to achieve 50 by 50. But we can also see, if you look at the past 31 years, you can see that 7 of the 30 most populous countries actually achieved 50% reduction in premature mortality over a span of 31 years or less. So these are actually different countries from the other 7. So this sort of demonstrates the feasibility of this goal. And an important component of this is the continuation of scientific advances. So a study looking at child mortality, 1970 to 2000, demonstrated that about 80% of the reduction in child mortality was attributable to technical progress. And technical progress has surely advanced beyond 2000 and surely will continue to advance all the way up till 2050. So while the first message was sort of the aim, this second message is sort of the route to that aim, and the Commission focuses on these 15 priority conditions. These are conditions that cause disproportionate amount of mortality and also have a cost-effective solutions. So we have, first of all, these are 8 infectious diseases, 8 infections in maternal and childhood conditions. These are neonatal deaths, low respiratory infection, and low respiratory tract infection, diarrheal diseases, HIV/AIDS, tuberculosis, malaria, childhood cluster diseases, which are then measles, tetanus, diphtheria, whooping cough, and maternal conditions, which are just maternal deaths. And then sort of a second set of conditions, the 7 non-communicable diseases and injuries, which are atherosclerotic cardiovascular diseases, hemorrhagic stroke, non-communicable diseases into infections and tobacco use, diabetes, road injury, and suicide. So these, like the video said, these 15 priority conditions account for majority of the life expectancy disparities between our region with the best life expectancy, that is Western Europe and Canada, which we term North Atlantic, and other regions. For example, about 80% of the difference for China, close to 80% for Sub-Saharan Africa and India as well. But of course, these need to be sort of tailored to the country-specific context. So, of course, the 8 infectious and maternal child health conditions are going to be more important in Sub-Saharan Africa, while actually the other 7 non-communicable diseases are in more context. So I'll think Sondra will elaborate a bit more on that.
Sondra, let us know about messages 3, 4, and 5. They're on health financing and health system strengthening. How are we going to potentially get this stuff?
Yeah. Thanks, Gavin. Thanks, Omar. So the third message here is that the universal health coverage and the health system strengthening agendas need a reset. And we're proposing a modular approach. So the WHO monitoring report from last year showed that there's been little progress in expansion of essential health services around the world, and that's apart from antiretroviral medications that people get. There's been very little in terms of other expansions of other essential health services. Compounding that fact is that there is increasing catastrophic health expenditure, incidence of catastrophic health expenditure around the world. And that suggests that the financial risk protection that's supposed to accompany universal health coverage is not happening. So based on these findings, we are calling for a reset, and we are calling on national governments around the world to publicly finance, focus on publicly financing these 15 conditions, as they are the ones that account for the biggest differences in mortality and morbidity around the world. And when we say publicly financing these, we're actually saying that it should be prepaid so that people have access to these services at the point of care without incurring any financial risk. And we've suggested a modular approach of 19 different modules. What you'll see on the screen, these are three modules that are focused on primary care. There are others that are focused on mortality reduction and also improvements in quality of life, like adolescent healthcare, rehabilitation, and all. These are not prescriptive. We do recognize that country contexts are different and that different countries will require maybe a subset of the 18 or maybe all of them. But we expect that most countries will actually get some modules from this that will be relevant for them, because we designed them to be broadly applicable and capture the major causes of the gaps in life expectancy and premature mortality. The fourth message we have from this commission's report is that countries should publicly finance a short list of medicines that are targeted at these 15 priority conditions. So previously we talked about making the services available, but this is specifically targeted at the medications. And that's because drugs themselves are a major cause of catastrophic health expenditure, and people make decisions on whether they would get their buy their medication based on their financial status. So we are saying that this country should publicly finance this, and we're naming this the Arrow mechanism. It's named after Ken Arrow, who is a Nobel laureate and acclaimed founder of health economics. He was a co-author on the first report, the Lancet Commission report that Gavin just talked about. The Arrow mechanism will have four main components. The first will be to redirect the current system of having budgetary transfers to the Ministry of Health, to redirect some of those funds to have line items that are targeted towards medicine, so that they are not diverted away from medicines procurement. The second component is that there should be centralized food procurement, because that will help governments to negotiate better prices and will also promote economies of scale. The third will be procurement of large volumes to ensure availability across the country, recognizing that availability might differ depending on the context within the country. And so having a lot of medications available will reduce inequities that might occur. And then the last component, the fourth one, is to use and strengthen public and private supply chains. Now, this is important because we don't want this to be another way for to create parallel systems, but a way to strengthen the existing health system to perform its function. The fifth message is that tobacco is the new tobacco. We've heard variations of this statement recently. Sitting is the new tobacco. Sugar is the new tobacco. We're saying that too much of sitting, too much of sugar, it's not good, but they are not the new tobacco. Tobacco is the new tobacco. And we know that tobacco taxation is the single most important intersectoral policy that can help achieve 50 by 50, and that's coming from our analysis. The task force on the fiscal health policy actually suggests that raising taxes on tobacco can do more to reduce premature mortality than any other single health policy. And so we're saying that the agenda to reduce morbidity and mortality from tobacco is unfinished. And so we should still focus on that agenda. So tobacco is the new tobacco. And with that, I'll hand over to my colleague, Dr. Justina.
So Justina, Sundu introduced us to modular health systems strengthening. And in the Global Health 2050 report, we introduced a new tool that we're calling modular cost effectiveness analysis. Justina, tell us how a modular approach to health systems and using modular cost effectiveness analysis can actually be useful for kind of national planners, for thinking through the scale up of interventions, clinical medicine. How could it be applied?
Thank you very much. I believe you can hear me.
Yeah, loud and clear.
Thank you. Good day, everyone. We continue by taking a deeper dive into modular health system strengthening and the modular cost effectiveness analysis as a tool for planners with a brief overview of practical application of the tool. When this document was launched, Dean told us to remember two numbers. But so for my segment, please remember two numbers and also remember one statement. Two numbers, 15 and 19. 15 priority conditions, 19 intervention modules, and the statement that it is not a prescription. Now, evidence suggests that an overly broad vision of UHC and a lack of focus on how to use limited resources to directly improve population health and build resilient systems have contributed to UHC agenda being limited in its ability to drive progress on health outcomes as much as expected. And of course, based on this, clearly a reset in the UHC and health system agenda is needed, like Osonu had alluded to earlier on. In line with this, we present a modular approach to health system strengthening that enables a build out from the 50 by 50 goal to allow for a movement towards a more comprehensive UHC over time. We therefore recommend that government should focus funding on a core set of fully prepaid interventions that are made available to everyone, starting with those that offer the highest value for money. And we have identified cost-effective and feasible core interventions, grouped these interventions into 19 modules. And these modules, in addition to addressing the 15 priority conditions, also include interventions that address other major demands on the health systems. And by so doing, they are more impactful and they are feasible and feasible to and sustainable. Now, these are crucial to achieving the 50 by 50 goal and improving quality of life at all ages. Each module represents a program area with specific set of policies and financing strategies and are based on the foundations of the health systems. And like I said earlier, it is very important to know that interventions are not a prescription and therefore should be locally contextualized and adopted based on local situations and circumstances. Now, these are the 19 intervention modules that are spread across various levels of the health system. At the primary healthcare team, we have interventions under infectious and maternal health conditions such as immunization, childhood illnesses, pregnancy, and childbirth. There are interventions under NCDs and injury and under health systems at that level. At the first level delivery platform, surgery features clearly under NCDs and injury, and we have emergency care functions under the health systems. And at the referral level, we have basic and advanced cancer care. Focused investment in country-appropriate modules to expand delivery of these interventions will definitely ensure and accelerate progress towards achieving the 50 by 50 goal. Now, although most countries have broadly defined health benefit packages with well-defined interventions, the implementation of these interventions are often poor because the cost of implementing them usually are much higher than available resources. And this is unfortunate because health benefit packages are key policy mechanisms for efficient resource allocation. And so this may result in countries having interventions that are not being implemented. To address this, we propose the modular cost effectiveness analysis approach that adapts to local processes, local system configurations, and local financing arrangements. Now, this approach occurs in two stages. In the first stage, planners identify a set of intervention modules that are contextualized to the country. Now, these modules will be organized around focused areas using different organizing principles made based on technical working groups and others. And then estimated spending on each module will be made based on ability to expand or reduce funding for each module with budgetary allocation based on national health strategies. The second stage essentially is a technocratic process where interventions are mapped by experts to their modules with definition of outcomes for cost comparison. Now, looking at this, what is the role of surgery in modular health system strengthening? And this is where we try to address the practicality of the report. It is important to bear in mind that surgery itself is an intervention. So when you look at 15 priority conditions, you don't see surgery listed there. But you can see, one can see that surgery is important in diagnosis, in treatment and rehabilitation across the 15 priority conditions. And this is reflected in all the conditions listed under NCDs and injury, and about 75% of the infectious and maternal health priority conditions. And then an in-depth analysis of the 19 intervention modules also show that effective implementation of surgical interventions is essential across a number of them. And very importantly, one of these modules focuses entirely on surgery. Now, this comprehensive approach will allow for strengthening of the surgical ecosystem, the entire health system, and ultimately enhance achievement of the 50 by 50 goal. Now, how can this modular approach be applied to health reform initiatives? Now, we'll take an example from Nigeria, based on work that we have been doing, trying to strengthen the surgical system. Now, one of the key reforms happening in Nigeria's healthcare system is strengthening of the surgical healthcare to facilitate achievement of universal healthcare. Applying the modular approach can help us to refocus the program and mobilize resources for implementation and sustainability. The approach is essentially a creation of priority areas which could include trauma and injury, maternal health conditions, congenital anomalies, and cancer and surgically treatable NCDs, and intervention modules of trauma and emergency surgery, emergency obstetric care, neonatal surgery, and cancer surgery and NCDs. And clearly, all of these fit into the 19 intervention modules with outlined key components that can be costed. This format allows for intervention mix as well within the modules and optimization of cost effectiveness, and also serve as an example of flexibility to conform with local context. Ultimately, the modular approach advances discourses around health system strengthening by shifting focus towards the 15 priority conditions. It can inform drug formularies and procurement systems, thereby improving access to and affordability of high priority medicines, and also guide conversations around workforce and bring attention ultimately to health information systems. Thank you very much.
Thanks so much, Justina. Turning to you now, Simao. So in the Global Health 2050 report, on page 21 to be specific, panel 4, you wrote a really remarkable, compelling case study of taking this modular approach and actually using it to guide the scale up of interventions in Shishu County in China. Tell us about that approach and how you applied it in that county.
Thank you, Gavin. Health and economic prosperity are the twin pillars of social development. The Lancet Commission on Investing in Health has set forth a visionary global initiative to halve premature mortality rates by 2050, an ambitious yet achievable goal known as 50 by 50. This endeavor necessitates the identification and implementation of critical interventions aimed at addressing 15 high-priority health conditions. China has long been at the forefront of enhancing population health and is a committed partner in the global health arena. Recently, we have launched a health and social development program in Xishui County, Guizhou Province in China. This program embodies the modular approach introduced by the Commission, focusing on interventions for prioritized non-communicable diseases. Xishui County, with its typical rural Chinese characteristics and relatively poor socioeconomic profile, serves as a microcosm of broader challenges faced across rural China. The goal is to deliver a comprehensive, cost-effective intervention package designed to improve the health of the population and, by extension, foster social development in Xishui County. We are also pioneering a pay-for-performance incentive mechanism for primary care practitioners to encourage them to care for population within their region rather than individuals. The project, launched by employing a key indicator, the loss of expected life years due to disease, to accurately identify the region's most pressing health concerns and prioritize interventions accordingly. The Commission has identified 7 NCDs and injury-related conditions as the predominant health concerns in China, which significantly contribute to the lower life expectancy when compared to the North Atlantic region as outlined in the Commission on Investing in Health. Notably, atherosclerotic cardiovascular diseases account for 1.4 years of the gap for males and 1.7 years for females, while hemorrhagic stroke contributes 1 year for males and 0.8 years for females. Non-communicable diseases strongly linked to tobacco use are responsible for 0.9 years for males and 0.7 years for females, and those linked to infections contribute 0.7 years for males and 0.54 years for females. After pinpointing these significant disparities, we delved into the root causes. We found that NCDs strongly associated with tobacco use are poorly managed, accounting for 24% of all NCD-related death in China. Chronic obstructive pulmonary disease, COPD in particular, is a leading cause of health and economic loss, yet it remains inadequately addressed at the primary care level. And our recent publication in Lancet series reviewed startling statistics from the Happy Breathing Program, a nationwide program in China, shows that only 41% of COPD patients had ever received screening. 17% had been diagnosed prior to the program, 8.5% were being treated, and less than 5% had achieved COPD control within a year. This underscores the urgent need to enhance primary and secondary respiratory care. Additionally, China's high cardiovascular mortality is linked to risk factors such as hypertension, air pollution, and tobacco use. Hypertension awareness, treatment, and control rates in China are lower than the global average, highlighting the need to improve cardiovascular care at the primary care level. Furthermore, China bears a substantial burden of NCDs linked to infections, including complications from hepatitis B virus infection, with mortality rates twice the global average. In response, we have adopted a modular approach outlined in the Commission to design 3 targeted modules aimed at tackling the 7 NCDs and injury-related priority conditions. Currently, we are focusing on NCDs strongly linked to tobacco use, employing an integrated intervention package that includes population by COPD and asthma screening and diagnosis, treatment for these conditions, digital health interventions for smoking cessation and mental health, and monitoring of blood pressure and blood glucose, all proven to be cost-effective. In the near future, we plan to roll out a cardiovascular disease module featuring a combination of drug therapies for individuals at high cardiovascular risk, long-term management of chronic kidney disease and heart failure, and more. The module for NCD strongly linked to infections will target Helicobacter pylori infection and hepatitis B vaccination to prevent liver disease and cancer. To further motivate primary care practitioners to care for population health, we have also designed a pay-for-performance mechanism based on the performance of the care cascade. In conclusion, this program is designed to ensure that the intervention modules for CPIGH are scientifically grounded, culturally acknowledged, publicly accepted, and politically feasible, all in the service of promoting social development. We are planning a program evaluation with a quasi-experimental design over the next 3 to 5 years to collect routine data from CPIGH and neighboring counties, thereby assessing the effectiveness of our modular approach. Thank you.
Thanks so much, Simao, for demonstrating the kind of real-world application of this modular approach. Lastly, we are going to close out with the final 2 messages. So far, the first 5 messages have been largely aimed at national governments. Messages 6 and 7 on pandemics and the future of aid are also aimed at an international and donor audience. Dan will pay. Tell us about messages 5 and 6. 6 and 7, sorry.
Yeah, thank you. I'll be presenting pandemic preparedness and international collective action on behalf of the Commission. So our 6th message is that there is a high risk of another pandemic of COVID-19 like. In the report, we estimated the number of deaths resulting largely from COVID-19 to be about 23 million excess deaths. And this was during the emergency phase of the pandemic. That's January 30, 2020 to May 4, 2023. Now, in a background study for the commission prepared by our colleagues, it was estimated that there is a 23% chance of a pandemic of similar magnitude to COVID-19, that is deaths equal or greater than 25 million. You can see that right there on the table on the screen. And this, yeah, like I mentioned, this can occur over the next 10 years. Another way to interpret this is that there's a likelihood that we experience 2.5 million pandemic-related deaths annually, which is a similar figure to the number of deaths we currently experience annually from tuberculosis, malaria, and HIV and AIDS combined. Now, in the report, we analyzed country performance on COVID-19 pandemic response, and we did so in terms of averting excess deaths during the pandemic emergency period. So what we noticed was that countries, there were variations in the way that they performed. But however, across the board, countries that employed the public health fundamentals averted massive mortality. And these fundamentals include rapid response, case detection and contact tracing, isolation of infected individuals and quarantine of those exposed persons. Last but not the list, social and financial support for individuals who are isolating or quarantining. Our seventh message is that there is a critical role for development assistance for health in supporting 50 by 50. And these are divided into two broad purposes. The first of which is direct country support. And these will be targeted at countries with the least resources, providing them with financial support, technical support, as well as disease control and modular health system strengthening. The second prong is that there will be support for global public goods for health, directed at reducing the spread of antimicrobial resistance, pandemic prevention and response, as well as sharing the best practices and the development of new tools, all with an emphasis on the 15 priority conditions. I'll now hand over to you.
One of the reasons that we're very bullish on R&D is that the Centre for Policy Impact of Global Health has just finished a study looking at what's in the pipeline. And based on what's in the pipeline, and based on a real sea change that's happening in the way in which R&D is being conducted, with AI and clinical trial networks and new modular manufacturing, we estimate that there could be around 400 to 500 new products, medicines, vaccines, and diagnostics for global health conditions before 2050. So we feel quite bullish, we feel quite confident, going back to Omar's first point about the role of science and scientific innovation in helping to achieve 50 by 50. So there it is, Global Health 2050, the path to halving premature death by mid-century. We argue that the case today is better than ever for the value of investing in health, reducing mortality and morbidity, alleviating poverty, and improving human welfare. You've heard our 7 key messages: 50 by 50, prioritizing 15 conditions through a modular health system strengthening approach, through modest increases in domestic health financing, that we have to be ready for the next pandemic. There's a very high risk of another one in the next 10 years, and that there's a critical role for the international community in providing development assistance for health, particularly for the countries with the least resources today, and for generating public goods and preparedness and response, knowledge generation and sharing, new tools for the challenges of tomorrow. We've left about, let me see, 17 minutes for a Q&A. I want to also make sure that those online have the opportunity to post their questions. So please go ahead. I can see your questions right here, right now. I'm going to take the prerogative of just kicking off with a rapid fire question to all the panelists. Perhaps starting with you, Justina, what impact do you hope that this report has?
Thank you very much, Gavin, for that question. I'm hoping that this report will transform how countries structure and reform their healthcare system for optimum efficiency and in a realistic, achievable, and sustainable way. So that's the impact I'm hoping that this report will have.
Fantastic. Yeah. Thanks so much. It's worth reminding folks that the WHO estimates that between 20 and 40% of all health spending is wasted, for example, for not using generics and other inefficiencies. So your point is very well taken. Simao, what impact do you hope this has? Not just in China, but worldwide.
Yeah, so the first impact is to scale up investment in health. Globally, we know that even if there are waste from utilization of healthcare resources, but the total investment is still not enough to maximize population welfare. So that's the first impact, to scale up investment in health globally in many countries. And the second impact, I think, is to answer how, the question of how to, what kind of interventions should we focus on, should we prioritize, and pinpoint the way that the government to invest in health in different countries, because each country has their own prioritizations. And so we are guiding the way, and this report is guiding the way and show the governments how to invest in health. I think these are the most important messages and the impact that the report has.
That's right. I think health has largely fallen off the global development agenda, which is a catastrophe. And I hope that this report helps to right that ship. And I think for many governments, as you're alluding to, they are not prioritizing health enough. And what we're arguing in the report is for something quite modest, an additional 1% of GDP on health investment in low-income countries, and an additional 2% in lower middle-income countries. Those are feasible increases, and many countries, China is an example, have shown that that can be done. Sondu, we're doing rapid fire down the line.
Okay.
Yeah, let's go for it.
I'm hoping there'll be less talk and more action. And that when we look back in 5 years, we will see examples of countries that have taken the messages and shown tangible results, and not several meetings and debates and all of that, just action and result.
And to Sondu's point, the next phase of this work is national country commissions. Nepal, for example, has announced that it will move forward with a national CIH 3.0. We're in conversation with the Nigerian government for a similar process, and we've heard about at least one county in China. So we absolutely hope national commissions are the next step forward. Yeah, we'll pay.
So on my end, I hope firstly that the report drives investment in health, as mentioned earlier, and through the actionable goals that have been laid out, also guides global progress in health. And last but not the least, this is also very important to me. I really hope that the report helps to rebuild the trust and global cooperation that have been.
Thanks, Tempe. Omar, our resident demographer. Maybe you'll give a demographic answer, but no pressure.
So what I hope is that the main message of this report will be taken seriously about the sort of targeted approach, sort of prioritizing the most urgent health conditions. So in this report, we shine a light on the causes of death that are, and consequently also causes of morbidity that are sort of most substantial. But that's only sort of one part. You have to sort of take this as evidence to and trace it back to the risk factors that contribute to these causes of death. And I really hope that, yeah, this report will sort of make a more targeted effort towards these risk factors.
And Omar said something profoundly important at the very start, which is this is a report that is aimed at every single country, every single one. And he also mentioned that the best performing region of the world, he called it the North Atlantic, that is Western Europe and Canada. There is one country that's missing in that group, and that is the United States, which is actually a poor performer compared to its peers. And one of the commissions that we are hoping to launch, we have a planning kickoff meeting next week, is the United States Commission, who do very poorly in a whole host of domains. So this is a plan for halving premature death in every country through prioritizing the conditions that are the main killers. Let's open it up to the audience. Oh, brilliant question from, I'm taking one from, everyone online gets forgotten, so I'm going first to everybody. How does this report tie in to the ongoing universal health coverage work that the World Bank, the Global Financing Facility for Everyone, Every Child, and other kind of global health initiatives are pushing for? How does it tie in? I'm going to be a bit cheeky and answer that first of all by saying that the universal health coverage movement is stalling, and that's part of the impetus for this report. Service coverage has stalled more or less since 2015, and catastrophic expenditures are getting worse or increasing. So whatever this push is, and we all believe in it, it is our, as I said, it's our guide star, it's our lodestar. We will probably all in this room go to our deathbeds believing passionately in UHC, not too soon, hopefully it's still decades away for most of us. We still believe in that mission, but something needs to be put right. There needs to be some kind of a reset. That's what I would say. But let me ask Simao and Justina, any thoughts? There's obviously a global push for UHC. Where does our report fit in with this global push, would you say? I'm going to go, yes, put you on the spot.
Thanks, Kevin. So actually, we also have a paper published in Health Affairs earlier showing that UHC, like you said, is the progress is stalling, and also from the coverage of from the financing perspective is also not invested sufficiently, especially in low and middle income countries. And the coverage of health insurance is very low from that paper. And in China and in many other countries, financing in healthcare is a big issue. And this report actually get in the way and shows that it's feasible in financing, and maybe adding some evidence in persuading the policymakers to invest more in health, especially in covering, especially in financing health insurance part, and from this kind of perspective. So I think that would be one of the major impact that this report will have to further push the progress of the UHC.
Thanks, Amal. Anyone in the room from the panel here would like to? Yeah, Sandhu.
I'll say it's related. We make very clear that the UHC and health system strengthening agenda needs a reset. And what we're saying is that you should focus on the major causes of excess deaths and suffering. And if you can start with these 15 priority conditions and address them, you can now expand forward. One of the big problems with universal health coverage, the universal health coverage agenda, is that for countries that try to do everything, we tend not to do anything well. And lots of arguments about what needs to be included in the benefits packages and all that, and different teams struggling for inclusion in these packages makes it difficult for countries to make meaningful progress if you try to do everything. What we're saying is focus on a small set, begin to get the gains, and you can add as you go.
Yeah, you can cut mortality early on the path to UHC. You do not have to wait for this perfection, this idea of this kind of perfect universal health coverage to start seeing mortality reduction. Justina.
Yeah. Thank you, Gavin. So what I think the report has done is to create a focused pathway for ultimately achieving that UHC that we all desire, right? And I think that's what everybody in the room has been saying. It's stalling, yes, but then we can be optimistic because now we have a pathway through which we can, from starting with a 50 by 50, ultimately get to that UHC that we are looking for. And I believe it also creates a very strong advocacy statement to funders, right? Because it shows the feasibility. There are clear examples backed up with evidence that this is possible and the 50 by 50 is achievable. So it shows that it's a very feasible pathway that has been created for this to be achieved. Thank you.
Let's take a question from the room. Yes.
Thank you guys so much. I really enjoyed the presentation. You mentioned specifically that there needs to be specific line items like essential medicines, etc., in your report. And you also highlighted the exciting development, particularly in R&D for that pipeline. My question is, what kind of access measurements need to be put in place to ensure that price and cost and monopolization doesn't occur like we saw during COVID, where a lot of these novel technologies were held primarily by high-income countries and not enjoyed by all?
Brilliant question. Who would like to take that?
Need some clarity on the question, though.
I think, you're saying that there are going to be new tools ahead.
How do we
make sure that they are
everyone
affordable and available?
Yeah.
And I think that, maybe I'll just quickly say, I think there needs to be those considerations built in from day one, right? Where are the trials done? Making sure that trials are then linked to, say, local manufacturing. Where are the trials done? Making sure that trials are linked to fair pricing in the end. If you're not doing that today, then that's not going to happen. We know that's not going to happen. We've just seen it with lenacapavir, for example, the most important HIV breakthrough prevention probably in a decade. And the first trials were done in South Africa and Uganda, I think, or Botswana, I can't remember. No manufacturing is going to be happening there. That's a mistake. The second trial was done in 4 middle-income countries in South America who have been banned from buying the generic version. So you can see the gaps. So we need to make sure those gaps don't happen in the future. It needs to be local manufacturing, there needs to be an access plan from day one.
Yeah, and that will address a lot of the cross-country differences and access concerns across countries, especially from high-income to low-income countries. Within countries, however, there is also the potential for inequities that might exist because of supply chain issues and also pricing. You might provide the drugs for free, but if the drugs are not available, people need to pay to go get those drugs. And so thinking about the cost of seeking care. So those things need to be built in from the get-go and that will be part of that will form part of the discussions around improving access to care. The line item budget will be the first step to make sure that that money is there. And that's an allocation decision. So the money is there, that can be spent. But the fact that the money gets there doesn't mean the money is used. The next level, if you recall the presentation from the modular, once the money is allocated, the next part will be how can we get the best value out of the money? So you need to tweak some of the technical issues, both within the country and also across countries. Those will be handled mostly by contracts, specifying details in the contracts, but it is possible and it will be done.
We've got time for one more question from the room. Yes, please go ahead.
Right. I'm Norbert. I'm from Sanford School of Public Policy. So you did kind of express that a lot of the bulk of this work has to be done at the local level. There's some things that we have to do at the international level. And when we look at the pandemic and, like US pulling out of the WHO during the pandemic period, what can be done to improve global cooperation in achieving this goal? And which bodies do you think can actually handle that?
It's a great question about improving global cooperation. I'm going to be very careful in how I say the next thing I say. I think some of that will rest on what happens in 12 days' time. In terms of multilateralism versus nationalism and looking inwards. And, you know, if you look at the pandemic, there has been a slew of initiatives since COVID-19 pandemic, from the pandemic fund sitting at the World Bank to revisions of the international health regulations to a pandemic treaty. Pandemic treaty has stalled. That's a huge problem. It has stalled over benefits sharing and pathogen access. Low and middle countries don't want to say they'll share the pathogen unless they get guarantees of vaccines. Rich countries are saying we don't want to be beholden to giving away our vaccines, and their industries say the same. So clearly we've got to find a way out of the PABS crisis. There is no doubt about that. So that's my first, that's one quick reflection for me. Simao, Justina, and everybody here, any thoughts on how to strengthen international cooperation to tackle the next pandemic?
To touch on the point about representation, I believe that we do need adequate representation of all the bodies involved, not necessarily it's skewed to one side or maybe countries or corporations that have like a lot of power. So it would be you know, from the bottom community level representation to the very top, you know, corporations, organizations, and the like. So we need adequate representation of all parties involved.
Thanks, Alma Ata. And lastly, we've got 1 minute left. Rapid fire answers, perhaps from Simao and Justina. Maybe you could do it as a haiku. Just kidding. That was a terrible joke. I've told that joke before. I don't know why I repeat it. It's a terrible joke. It never landed the last time. I don't know what I was thinking. Anyway, Justina and Simao, any final thoughts?
Well, I think countries need to be more to realize more that the whole world is now one single global village, right? And a pandemic, something happening in one part of the world can easily spread across to the entire globe, throughout the entire globe. And if we sit on that and have that always before us, then we will be able to allow ourselves to have collaborations across countries. But when you keep on with a nationalistic agenda, then we are really not going to move forward. Thank you.
Simao, do you want the final word?
Yeah, thanks, Gavin. I fully agree with all the commissioners' comment, and also from the pandemic, it shows that even if we have contained the pandemic in several countries, if there is one country that cannot do the containment, then in the end, we are losing the fight. And so enhancing multilateral collaboration, strengthening the role of international organizations, such as the World Health Organization, the United Nations, and maybe World Trade Organization, etc., allows countries to engage in dialogue, share best practices, and develop coordinated responses to global challenges.
That's a fantastic place to end. So that just leaves me to thank Simao, Justina, Omar, Damope, Sondu. Thank you all of you for joining. The report is available at globalhealth2050.org. There's also a 2-page policy brief and a video. And with that, I wish you a good day.
Thank you. Thank you.